All right. 1 second and we're good to go. Perfect. Ladies and gentlemen, welcome back to our international ground rounds. I'm very pleased once again to have one of my mentors, Professor Hesham Saleh from London. Good morning, Hesham.
Morning, Puya. Nice to see you again.
So today's topic is static orbital decompression, one of those very, very interesting topic, which is a combination between ENT, rhinology, surgery, and facial plastic. So I think that it's important to highlight some important findings and some techniques, which Hesham is one of the most potentially a very well-known surgeon in the world. So Hesham, if you could share your screen, please. I will remind all the attendees to type your questions, and we will reply to your question at the end of his talk.
Great.
Please.
Thank you so much, Puya. Thanks again for inviting me to Nazostano. I'm going to talk about aesthetic orbital decompression. We obviously, whom of us who do rhinology or like complex rhinology, we do in orbital decompressions for thyroid eye disease. But I'm just going to specifically talk about done for cosmetic or aesthetic reason, and I will tell you about it in general before that. So, interestingly, I've been working with ophthalmology for a very long time, so I still get letters all the time says consultant ophthalmologist. They confuse me now because for many, many years I do a list every month with ophthalmology. So people think I'm an ophthalmologist. They send me the journals and everything, but I'm not really. So I've had a lecture from Professor Kennedy. So Professor Kennedy, David Kennedy, in 1990, wrote a paper about 5 patients who he did endoscopic transnasal orbital decompression, for the first ever to be reported. So he was the first to report this. And he reported the medial and inferior wall for thyroid eye disease when these patients that he did had complications of thyroid eye disease like ecchymosis, vision problems, and so on. So it was the birth of that technique. And sooner after that, otolaryngologists started doing it. My first one, I was in training in 1996. I did my first orbital decompression when I was doing my advanced sinus surgery training. And since then, I've been doing a lot. So it's described as an ENT. You see that our access endonasally is to the lamina papyratial media here, but also you can access the floor. So the description was to do a decompression of the medial orbital wall through the ethmoids from here and part of the floor until you reach the infraorbital nerve. And this is the extent you could do endonasally through the sinuses. The advantages were very obvious from the beginning. There's no scar. The complication rate is really low because you get a bit of bleeding and so on, but not that much. Is completely in contrast to having an open decompression that was a standard technique prior to that. And plus that is a quick recovery. So it became a very popular operation for patients with thyroid eye disease, which is the main indication. So as you can see this patient here has ecchymosis, which is this conjunctival edema like this. They have proptosis. They start having redness and injection of the conjunctiva. Plus, you can get dryness, keratosis. You can get vision problem if you have optic nerve decompression, and so on. And this is a standard X-ray or CT scan of patient with orbital thyroid eye disease with very thick muscles here, pressing and extending that orbit. So these patients were treated initially with medical treatment and so on, and then they get referred for surgery if needed. So the indications for the decompression were optic neuropathy. That was the first indication. They started having failed eye vision and they tried corticosteroids, sometimes even radiotherapy and immunosuppression. Then they get referred for surgery. Keratitis, dryness of the cornea, they're also a very important indication. And thirdly was cosmetic. Some patients will have mild proptosis and there's no other signs or symptoms, dryness or anything else. They just don't like the appearance. But that was a small number because the majority of patients presented severely like this and had extensive medical treatment. Somehow, medical treatment improved, and it's roughly in 2006, the shift between patients coming for complication changed to aesthetic. So when I looked at my patients that year, 2006, I was doing analysis of my patients. From the beginning, when I was starting in 2002, I was doing a lot of patients for complications of thyroid eye disease, keratitis, and so on. But gradually, the medical treatment improved so much, so the patient with complication dropped. So we started having more of the patient with aesthetic reasons. So nowadays, I do it more for aesthetic appearance more than the complications because of improvement in medical treatment. Even biologics now are involved in the treatment of this condition, and they are very effective. So that's why the numbers of these patients presenting with severe complications is really low. The numbers of patients developing slight proptosis and so on is a bit more now. So we do a fine cut scan for all these patients. This is a standard patient for open decompression, and the muscles are not as thickened as usual because they've had medical treatment. So sinus anatomy is good. I always need a good scan here because I want to detect how high the height of the lamina papyracea. It will give you an indication how much decompression I do. And I will tell you later, of course, you can do the floor, but I'll tell you why we don't do the floor that much nowadays. So the standard technique is like we do with our sinus surgery is complete sphenoidectomy. You need to open the whole structure. So here's me doing the right side. This is an uncinectomy. I've exposed completely now. All the ethmoids have been open here. This is a large middle major antrostomy. You can see that lamina papyracea is showing the color of the fat underneath is yellowish, and this is a sphenoidotomy in the back. So we create that large axis so we can peel off this lamina papyracea. And then I use this freer elevator to elevate that bone from the lamina. So here's the lamina from anteriorly, from lacrimal bone, all the way back to the sphenoid, which is open here. And then I peel off simply with the freer all the way back to the annulus of Zen, which is where the muscles of the eye are inserted. And then that's your limit of dissection. So to the skull base, to the maxillary sinus, to the annulus of Zen. And you can see here, that's the canal of the optic nerve and the carotid arteries here within the sphenoid. So that was the standard thing, which I'll show you in a video now, in a second. In the past, we did a lot of removal of the orbital floor. So I put plus minus here. I'll talk about this in a second, in a minute, but we'll go back to it. After that, you open the periosteum with a sickle knife like this, or just a keratome, and you get bulging of the fat. You can control this as much as you like. You can do a lot. You can expose a lot of fat, a little bit of fat, according to the response. Immediately, you can see it on the table, and you see how much decompression you've done. If you need more, you can expose more. Here's the video. So nowadays, I'm using the debrider. I'm even doing the uncinectomy with the debrider. This is the left side. And the dissection is straightforward because there's no disease. So in the majority of cases, obviously, there's no sinus disease. So less blood, open the bulla here, and then I'm creating a small antrostomy. I always create an antrostomy to prevent sinus infection because in the past, they reported lots of sinus infection if they didn't create antrostomies. So I've middle major antrostomy, open the posterior ethmoids here, all the way back, and here finding the sphenoid. Why do I find the sphenoid? It's a good landmark, so it's the limit of my dissection. So I'm going within the superior meatus here, creating some sphenoidotomy, and now I have exposure. You can see that optic nerve, optic canal, and the carotid optic recess here to the skull base. Whole skull is exposed. Now I'm cleaning lamina papyracea, so I have complete exposure. So you can see the skull base, you can see the frontal sinus as well, and you can see agarnesia. I opened it here on the left, on the right side. So then our lamina is very thin, as you can see. I think the best instrument to open it with is the freer because it's blunt, so it doesn't penetrate into your periosteum. So you just gently lift the lamina papyracea. I lift it all the way back, and it comes off nicely. You can see the periosteum immediately with the color, and sometimes you can see the color of the medial rectus muscle, which you have to avoid. So I'm lifting the lamina papyracea all the way back until the bone is thick, which is you can always feel it immediately. So all the way posteriorly and up to the skull base. Now it's all exposed. This anteriorly, I use the seeker, the ball seeker, to peel the anterior part of it. That's the easiest instrument. Again, because it's blunt, it doesn't penetrate into the periosteum. And then cleaning the remnants of bone with the debrider. Sometimes I wash it to make sure there's nothing floating around. And here's just a remnant of bone again, just a little bit. Now I'm using a keratome, not a sickle knife here because it was not sharp. A keratome I borrowed from an ophthalmologist. I open from the back posteriorly to anteriorly because you don't want the fat to expose appear in your view and you can't see. And then all the way down, just above the floor of the sinus here. And you can see the fat exposure, very gentle cutting on the periosteum does that. When you've reached that stage, you can then just very gently pull it. So I'm pulling that periosteum medially into the nasal cavity and exposing more. If you need more decompression, you can use a blunt instrument. This is just an arterial forceps. opening the small septi between the of periosteum between the fat. And you're looking, all while you're doing, at the same time, you're observing from outside how much decompression, so you can control the amount. So that's a scan of a patient who had decompression years ago. And interestingly, you could see the periosteum has reformed here. So it's actually protected. So it's thick enough. So you're not going to worry about this long term. So I looked at some of my patients a long time ago, and just 100 patients, to see the amount of decompression we can get from this type of surgery. And the age range you can see is very big here at that time. So the younger ones were mainly aesthetic, the older ones had complications. So it's much common in females. And the range is from 2 to 11, because it depends how much we wanted to do. 2 millimeters, small, but this is the aesthetic patients. Just do a medial decompression, a little bit of decompression, just to adjust the level of the decrease that proptosis. And up to 11 millimeters, which if you do the floor as well. And with a very low number of complications, less than 1% had maxillary sinusitis. That's why we always do maxillary sinus antrostomy. I did not have any orbital infection, no CSF leaks, no eyesight deterioration. And from that year up till now, done many more than this, and it's roughly the same numbers. But this is the interesting thing I wanted to show, because when we used to do endoscopic decompression, we always did medial and inferior wall, and the rate of diplopia was very high. We discovered that in 2006, a long time ago. At the same time, other people discovered. And 7% of our patients had to use Prism for 6 months, and 6% needed muscle surgery. Remember this for extensive decompression, floor and medial wall, for severe complication, not for the cosmetic ones. And we realized, and others realized, the reason is that this is a biased decompression. When you do floor and medial wall like this, you pull the eyes inferiorly and medially. So you get squinting, so you get diplopia. It's common. As you can see this patient here, see how much squinting there. At the same time, when we discovered this, publications were showing how huge the diplopia percentage in patients who had medial and inferior decompression compared to medial decompression only. And people started thinking about alternative, which is doing combined decompression, including lateral wall and medial wall, or 3-wall decompression, which was similar percentage to diplopia. And in Charing Cross, we have indications for ones that non-cosmetic, more than 30 millimeter, health failure, that's a proptosis. We do lateral wall by the ophthalmologist through a small incision, and medial wall. If it is small, the cosmetic ones, only medial wall decompression, which I'll show you now. So aesthetic decompression is only medial wall. Yeah, and so you don't get much diplopia. And I will show you examples in a second. It's really important to assess the patient expectations here, because like any aesthetic procedure, patient expectations has to be realistic. And you have to really explain to them process and the whole process, how they're going to go through, and a possible complication and everything else, which is very low though. And really important that we don't always get exact symmetry. Even if on the table it could look really symmetric, with healing you may get a bit of fibrosis or something, although to be honest, in the majority of the time they're almost symmetric. So you just have to explain that to patients. So now I'll show you examples. The patient come to me with pictures prior to that thyroid eye disease, like this patient here. This is what my eyes before I had thyroid eye disease. I'll show you in a minute. This is another one as well. This is my eyes before. I want to go back to this. Can you go back to exactly what it was? Probably not, because you're doing a medial decompression. It's not going to be exactly the same. Explain to them though, and as long as you understand the sequelae, it's fine. So here's that patient with this picture prior to the thyroid eye disease, and this is how she presented. She actually doesn't have any other dryness or symptoms or anything. She had thyroid eye disease for 2 years. Interestingly, ophthalmologists sometimes offer lid lowering surgery for these patients. Okay, so they still have the proptosis, but she was offered lid lowering, and they all referred to me by ophthalmology, by the way. I don't see them directly. So she had a second opinion from another ophthalmologist who decided she needs a decompression, not lid lowering surgery, and she was referred to me. So here's a scan, which is good scan, normal sinuses, muscles are not that thick. So medial wall decompression, and that's her. So I think we got her eyes to be similar to what she was. So it's a small decompression. If you look at the fat pad before, below this, in inferior fat pads, you look a bit less as well, because the orbit has gone back a little bit. And she was happy with that. Simple medial decompression. And she had very mild diplopia and settled down. In my experience, none of these medial decompressions need any surgery to the muscles at all. So did not have the lid surgery. This is an example. Another one, even more mild. Yeah, you can see a little bit of exposure. It's not that much, but you can see that prominence of the lower fat pad just because of that proptosis. And 4 years history of thyroid eye disease, purely cosmetic. And you can see the muscles are not very thick now because she had the full treatment. And again, that's medial decompression. And we got to this with much improvement to that fat pad as well. It's almost like you're thinking close to a blepharoplasty. Not exactly, because you're pushing the whole orbit backwards. Another patient here, a bit more severe, but interestingly, so this, she had the leg lowering. And that's the problem here. It almost looks like ptosis. So a lot of ophthalmologists don't agree with doing lid lowering for these patients, but this is what she had done. She's still unhappy with the proptosis, still seeing that her eye, she still has that exposure here, below here. So she was referred to me. I said this history for 7 years. And interesting, some of these patients with thyroid eye disease get worse after pregnancy like that. And here one we've done it, there's improvement because the eye is back, sitting back. So again, the level of this proptosis has gone down. And I did actually minimal decompression here, and she was fine, no diplopia. This is a bit more severe, and you can see even the upper lid fat pad is thickened, and here as well. 5 years history, she's never had surgery. And again, pure endoscopic decompression, no other surgery, and improved the appearance. Even you can see it from the frontal view, that's got flatter, and the fat pads here got flatter, and from the lateral view. So purely cosmetic. And her mild diplopia, again, 3 months settled. So the majority, if they get it, is about 11% of them. 3 months settles down. This is a lady I've showed, again, picture of grip before the thyroid eye disease, and this is now, it's a bit more severe here than here. It's quite prominent. Referred to me with 3 years history of thyroid eye disease to do a decompression more on the right than the left side. And what I did here on the table, you can see the muscle a bit thick here. I did both sides, but I found that the right side needs a bit of the floor. So I did a little bit on the floor here to get equal decompression. So that's probably one of the very rare ones I had to do a floor decompression, a very small floor decompression. And she had diplopia for much longer. So that's her before and after, so that I got them symmetric. You could see the complete different here. There's no bulge at all. So I had diplopia last longer, but it still settled down, just simply because she had a floor decompression. Finally, this is an interesting case, and I had a couple of these cases. This was referred to me. Her brother is an ophthalmologist, right? And she herself works as an optometrist anyway, so she is in the business. She never had thyroid eye disease, but she has severe myopia, -11. So she has large eyes. She's a small person, large eyes. She has proptosis, no history of thyroid eye disease, severe myopia, previous refractive surgery, laser surgery. She wanted to reduce her eyes, and after being assessed by ophthalmology and her brother and also the consultant ophthalmologist referred her to me, they asked me to do medial old decompression. No thyroid eye disease, remember that. So normal muscles, so no muscle thickening, just large eyes. So I did simple medial decompression. His scan showed good muscle, good axis here for the lamina, and that's it. So you could see it clearly on the lateral view. I mean, she's a bit laughing here, so she's a bit close her eyes. You could see that the eye has gone back, and a very mild diplopia for 3 months. So, so my conclusion is that endoscopic management of orbital disease is safe and effective. Complication rate is really low, and decompression for aesthetic reason is justifiable in carefully assessed patients. So have to be assessment jointly between otolaryngology, rhinologists, and ophthalmologists, and to agree with the patient, explain everything to them, and then to be done safely. And as I showed you in a couple of patients, that lid surgery may not be required or less required after orbital decompression. So that's it. That's the conclusion. Thank you very much. We can have questions.
Thank you, Hesham, for your presentation. We have some questions. Let's go for the first one. It's the first question is coming from Italy, actually. What are the postoperative care in those patients?
Yeah, so it's very similar to endoscopic sinus surgery. So get them saline douches. And I actually, I give all my patients a decongestion for maximum a week, decrease bleeding, decrease the inflammation and the swelling. I don't give them antibiotics, by the way. Yeah, so just decongestion, analgesia, because they do get some pain, because the periosteum is very sensitive. So it's more painful than endoscopic sinus surgery. So I have to make sure that we give them strong analgesia, plus washes for about a month, the rinse. That's it. Most important thing, no nose blowing at all for 2 weeks, because they will get emphysema immediately. I remember one patient who actually had decompression for thyroid eye disease, and she was very, very big. She was extremely obese, of a BMI 44. And when she was waking up, she was coughing, and then she blew her nose and immediately had severe emphysema on the table. Yeah, and looked very scary, but obviously settled down. So that's one important thing. And they do settle down. We explain them our diplopia. So our MDT, multidisciplinary team that works with ophthalmology, every patient after decompression, they see the ophthalmologist in the morning. So they assess them for diplopia, because if they have diplopia, they give them a special prism to wear, which avoids the diplopia until they settle down. So that's it. Yeah.
Another question coming from Sweden. Have you ever noticed patients complaining about skew deviation?
Deviation of what?
Skew deviation, I guess.
Skew deviation, meaning squint, I think.
I don't get it exactly, because skew deviation is tilting your...
like this. No,
yeah.
but no, it shouldn't happen, because that's only if you remove the whole floor, then you get ophthalmos. And no, I've not had that, because we're not able to remove the whole floor anyway, which is good, because you have to go through the infraoptic nerve if you do this. So we don't. So it's impossible to happen, in my opinion. I've never seen it. I've never ever seen it. Yeah.
Mexico. Are you packing the nostril post-operatively?
I never pack the nose at all after surgery anyway, even after standard sinus surgery. If I use anything, I use nasopore, which is very soft, small part. But in orbital decompression, I don't put anything, because I don't want to push the fat. So I don't put any packing at all. And that's why it's important to use a decongestion to prevent the bleeding, decrease the bleeding.
It happened to me one time. I packed the nose, and suddenly you have a complete enlargement of the eye, because the patient during at the end of the procedure, when the patient was waking up, he suddenly had these eyeballs. I was like, well, I remove it immediately. So another question from France. They are asking, are you prescribing a post-operative CT scan?
No, you don't need it. The scans that I showed you here, I very rarely have a scan. That patient was complaining of possible sinusitis. That's why I have the scan. But normally you don't need the scan, because it's not going to show you anything. I mean, you need to assess a complication or something. Yes, of course, but not a standard.
Same question from France. What are the main risks of balanced decompression?
The main risk is diplopia. If you have a permanent diplopia, is a major problem. But we have discovered, and we've shown, and other studies shown as well, that if you just do medial decompression, it's temporary, because the eye adjusts itself. But the one important thing is that you make sure you avoid medial rectus if you're doing the decompression. Some surgeons actually describe not removing the periosteum in the middle, above where the muscle is, so you don't touch it. But if you're very careful, you're not going to injure it. I've never injured it, and I've heard about a very rare complication like this. So this is the main problem, because if you injure the medial rectus, they will need surgery to correct the squint. Obviously, optic nerve injury is very unlikely, because you can see where you are. So we've never had that as well. These are the main two risks for CSF leak. Yeah, there was one report of a case of CSF leak in the UK. But I will tell you that was like 15 years ago. It's extremely rare, not in my series, and somebody else's. So yeah, you just not sinus surgery. So very simple.
Another question. This is an interesting one from Spain. Is any one of your patients complaining about epiphora post-operatively?
See, everybody gets irritation of the eye when you're doing this. When you see them immediately after the operation, the conjunctiva is so congested, it's so injected, as they call it, the ophthalmologist, and the eye is watering. It's stimulation. Yeah, they water, but for a few days. It's very common with them. But the epiphora, because of the lacrimal duct obstruction, no, because you're not going to go that far anteriorly anyway.
Another question is from Greece. How will you manage bleeding from the fat?
Yeah, if the fat bleeds, very gentle bipolar diaphragm. Yeah, we've not had that because the fat is not that vascular, so you will get minimal bleeding. When you put some epinephrine on it, it will stop anyway. But theoretically, if there's a tiny artery or something, you can use very gentle diathermy in a very low current, and that'll be fine.
The question from Marrakesh. There's so many questions. It's very
That's
interesting.
good.
This time there are very many. This colleague is asking if you're using corticosteroids postoperatively.
Yeah, we use it intraoperatively. Yeah, not postoperatively. So they have a large dose of dexamethasone injection when we put them to sleep. Always. Yeah, it really helps because dexamethasone is long acting anyway, so it's enough usually one dose. So it's good enough.
This is my question. Is mainly a female pathology or a male pathology that you're experiencing?
The majority of patients are women for two reasons. Because thyroid eye disease is common in women. It's about 3 to 1 anyway. And more women seek cosmetic surgery. So yeah, complication-wise, when you see them, it's more women again, because the more patients are women. That's the reason. Yeah. But the cosmetic ones definitely much more women than men.
Perfect. Thank you for your time, Hesham. Thank you for doing the presentation. Is there any upcoming meetings where we or our colleagues can find you in the next few months?
Yeah, sure. If you are interested in rhinology in general, obviously there's the Rhinology World in St. Petersburg in July, so I'll be there. Prior to that, I'm in Miami. There's advanced rhinoplasty course, if interested in rhinoplasty, in Miami in May. Then we have the European Academy of Facial Plastic Surgery in September. I'm in a couple of meetings in Spain, 2 meetings in Spain after that, rhinology and ENT. There's lots of nice meetings coming, but I think from April to May onwards, a lot of meetings. So you're not going to be short of meetings. But I think the biggest one will be a Rhinology World in St. Petersburg, in Russia, in July, 11th of July.
Great. So thank you for being with us. I will remind all the attendees upcoming meeting for the February 22. This is going to be the last for this segment. Then we are the next one is going to be with the Narayanan Prepajaran from Malaysia, and his talk is going to be focused on patients' preparation for endoscopic sinus surgery. I'm suggesting all the juniors, residents to watch that one if you want to master the patient's preparation for endoscopic sinus surgery. Thank you, Hesham. Once again, you will be invited, of course, for the next segment too. It's a cycle. I'm really enjoying in Hesham in our
me too.
Stay
Thank
safe,
you so much,
everyone.
Puya. You take care and hopefully see you soon.